Hello, and welcome to the Early Childhood Health Consultation December webinar titled Consulting the Rainbow, Updates to the Wisconsin Childhood Communicable Diseases Chart. My name is Maria Morgan, and I'm the Assistant Director with Early Childhood Health Consultation. Our team is so excited for you to be joining our webinar today. Our program is in partnership with the Wisconsin Department of Children and Families, housed at University of Wisconsin-Madison School of Human Ecology, and funded by the Preschool Development Grant. Our program is committed to supporting Wisconsin early childhood education providers in supporting health and safety practices. Our program envisions a sustainable and statewide model working through health consultation and centrally focused on promoting the health and well-being of children across the state. The Early Childhood Health Consultation Program acknowledges the American Indian tribal nations across Wisconsin and commits to a partnership to offer tailored support in best meeting the needs of each tribal community. Our program offers general guidance on best practices for health and well-being within early childhood settings. Any questions about a specific child should be directed to that child's primary care clinic. For today's webinar, we will start with introductions, have time for central content, question and answer, and a few closing remarks. If you're interested in receiving credit with the Wisconsin Registry, please stay tuned to the end of today's live webinar event, where we'll include a link to a survey for you to enter those details. If you've registered for today's event, you can expect an email with a link to today's recording, a link to today's slides, and resources for your later reference. This recording will also be made available on our YouTube channel. There's a couple webinar features available during today's live event. Feel free to utilize the chat feature throughout today's webinar, where you can use the drop-down selection and send your message to the host and panelists or to everyone. We also have the Q&A feature. There you can type your question throughout today's webinar and use the chat box if you'd like to send it anonymously. If you join Zoom through your cell phone, the chat and Q&A features are found at the bottom of the panel. And with that, I will turn it over to Dr. Depesh Nazvaria to tell us a little bit more about today's learning objectives.
Thank you so much, as always, Maria. Today we'll be talking about how to access the Childhood Communicable Diseases charts, which many of you are likely familiar with, but in case you're not, we will tell you how to get to them. We'll talk about the 3 key criteria for temporary exclusion from group care. We'll talk about different approaches for using the updated chart within your early childhood programs, and then, of course, how ECHC can support you in all these ways. So our scheduled speaker for today is Dr. Suzanne Gibbons-Bergener, who's an infectious disease epidemiologist from the Wisconsin Department of Health Services. We were expecting her, and she has not appeared yet. We hope that everything is okay. If she shows up in the next few minutes, we would certainly get her on. But luckily, I had reviewed her slides in advance and had gone through a few things, and we are actually well familiar with the chart as well. So I'm going to go ahead with her slides because most of them I can happily talk about. I may not be able to put some of the nuances on there around history that she's laid out, but certainly we can offer you a lot of comments and thoughts about the chart. And if she shows up in the next few minutes, we will gladly hand it over to her. So again, these are her slides, and I'm pinch hitting at the last moment here. So we'll move, this is our agenda, walking through the objectives, the evolution of the wall chart, and of course the updates that were made now in 2024. And again, we just went through what our learning objectives would be. So this chart has been around for quite some time. I realize this is very small text, and the point is not to actually read the text, but to recognize that the chart on the left is a piece of paper. You can even see the fold mark in the middle there of this scan. So it actually predates us having easy web access to things, and has been there as a resource for people in Wisconsin to think about common childhood communicable diseases in different ways. You now look at the right there, and you see, a more of a web-based, well laid out version that's easily updated, but also easily accessible in different ways. So these bits of guidance, the old paper chart as well as the more detail, have come together into something that on the right there, I hope is relatively familiar to you. This is what is commonly known as the rainbow chart, hence the title Rainbow Evolution. This is easily spotted from across the room. This is probably at least the second, if not third or fourth version of the rainbow format. And again, it lays out all the information in a single place that we'll be spending some time exploring together. So this is how you can find this chart if you are not familiar with it. This is a free resource, all made by the Wisconsin Department of Health Services, by the Communicable Diseases folks. And this is your state tax dollars at work, okay? They are spending their time to put all this information together, make sure it's accurate, and lay it out in a way that is hopefully usable to you and useful in many ways. If you go to that web link, it has all the forms of the chart in different ways. And you can choose to use it on the web, or you can choose to print it or request a printed copy as well. So in 2024, they have what they're calling the triple rainbow. You can access this on the web. So if you want to make sure you're looking at the absolute latest version right in front of you, you can go right to that site that was there before. But you could also choose to print it yourself. You could print sections of it or parts that are useful and pull it out in different ways and so on. And then, of course, you can request printed copies from DHS that if you don't have a large format printer or want to have the whole thing held up, that is a different way to access it as well. So let's talk through what you will see on this chart in different ways. This is the headings that you would see going from left to right. They're a little bit different from previous editions, but largely the same. Remember that what this chart does is it largely tells you about various disease entities, okay? So what is the actual disease? It is not based on symptoms for the most part. And this is a little bit backwards from how, most of you will think about things, right? Your job is not to diagnose a patient, right? That is my and my colleague in healthcare. It's our jobs to make a diagnosis. So you're not going to get what would be absolutely great, which is like, oh, are you seeing a runny nose? If this, then that, right? I wish healthcare was that straightforward. It's not. So instead, this is kind of to help you once a diagnosis has been made for the most part. So it'll give you the disease name or what's causing that illness, a virus or a bacteria or something like that. It'll tell you how it spread, right? If COVID has taught us anything, right? There was a lot of, hey, how is this spread? Is it direct contact? Is it airborne? Is it foodborne? All of those sorts of things. So it's helpful to know how it spread because that would help you think about your cleaning and other things. I do have I'm glancing at the chat as well, and I do see a note here from Lauren. Yes, it should be fully accessible outside of Wisconsin. If Maria or Kristen or any of our other staff who are on can just double check that link and maybe even put the link directly in the chat, that will be helpful just to help people get directly to that page. Thank you. Then there's the incubation period, which is how long between when you're exposed until symptoms appear, and so on. Kristen, if you can make sure yes to everyone. Thank you. I appreciate that. So incubation period is time from exposure to symptoms. You do not become ill the moment you're exposed. It takes a while, and that can vary for different organisms. What are the signs and symptoms typically like? As we frequently say in healthcare when we're working with our trainees, unfortunately, these viruses and bacteria and all don't necessarily read the book. So sometimes they are not sure, they do not always classically present, but that is our problem. Um, What are the criteria for exclusion? This is probably one of the things that you care about the most, right? When should folks be staying out of any group care, schools, and frankly, any other activities, right? If a child shouldn't be in an early childhood setting, they should also not be like in soccer or play groups or things like that. And then finally, what are the control and prevention measures that make the biggest difference to you on a regular basis? Next slide, please. So there are a couple of special disease designations which are important to note. One is the stuff that is reportable, okay? Reportable does not automatically mean it's a terrible, awful illness, although there tends to be a lot of crossover with that. But it means if this is happening, that this is something that the state health department or your county health department would like to know about. If you report to the county, they will make sure the state knows as needed. And it really lays out, they want to know so they can count and see, is there an outbreak? How is this spreading? Who is it spreading to? Is there anything else they need to do around control measures or things like that? A common cold is not reportable. We would overwhelm the county health department. It wouldn't make any real difference. But measles is reportable because, gosh darn it, if we see a case of measles, we want to know. We want to know who that person who was exposed to them, and so on, because measles is a deeply, deeply contagious illness. Makes COVID look like nothing, right? So that's what reportable means. The other designation is vaccine preventable, right? Let's recall that many of these illnesses, including some of the really bad ones, and the ones that can have bad side effects or complications to them, are largely preventable, or at least we can reduce the spread or reduce the severity through the use of safe, easily available vaccines that are covered for just about everyone. Okay, so recognizing that you see them on the chart, but you may never ever see them in real life, and we want to keep it that way. I, for example, as a pediatrician, have had the good fortune to never see a case of measles, and I hope I never do. Although sadly, with some of in the last few years, we are seeing some cases pop up. So it may eventually happen, although I hope it goes back to being something that is so rare that I can reasonably hope that I never see it. All right. So the chart, if you think about the rainbow, why is the rainbow there? It's because they decided to use a particular color for each system of the body, broadly speaking. So the first, and it's multiple systems, but that's okay, is the eyes, ears, nose, and throat. And I'm sure we could make a great song to sing with preschoolers based on the communicable diseases chart. I will leave that as an exercise for all of our listeners on today's webinar. So, and it shows you this different conditions, many of which you should have heard of. Cold sores, mononucleosis or mono, mumps, pink eye of various sorts, and then strep throat and scarlet fever. Now, I want to point out, right, some of these are very specific. For example, strep throat. Strep throat is a very particular entity. It is treated in a certain way. They do provide you with some alternate names for it. It might be called streptococcal pharyngitis or group A strep or something like that. Others are more general, like pink eye. Pink eye is a layperson's term, and that's okay. We generally know what it means. But you notice it can be caused by bacteria, but it could also be caused by viruses, as it tells you in the parentheses there. I'll note that mumps is one of those vaccine preventable illnesses. It is also reportable, hence those little icons that are there, and so on and so forth. Next slide, please. Then we move down. The orange is our respiratory. And there's a few things to think about here. We have, again, many of these should be familiar. We have influenza. We have pertussis or whooping cough, which we are seeing a lot of in healthcare. And I know that many schools have been dealing with this and childcare facilities as well, and so on. RSV or respiratory syncytial virus, which again, you may recall from previous webinars or our podcast. RSV has been around for a very long time. It's actually very common. We just didn't realize how common it was because we largely haven't tested for it, because if someone's not being hospitalized, knowing that they do or don't have RSV actually doesn't change anything. But, next slide, please. There's something new here. There's a line there called other respiratory illnesses or respiratory illness of unknown cause. This is a really, really, really important line, and I want to highlight this because this covers a whole host of things. If you could advance that, please, Maria. Thank you. Um, this covers COVID. It covers rhinovirus, enterovirus, adenovirus. I could keep going on a long list of names there. It covers pneumonias. It covers all sorts of things. It also covers the common cold. Okay, so do recognize that. So this line covers probably what you will see in most kids most of the time. Okay, so it may seem a little technical. Oh, it's this other viral illness, so whatever. Yeah, this is basically the grab bag that includes everything else. Next slide, please. Moving through the rainbow, we're now in the green zone, and green might be appropriate given the color of vomit sometimes or diarrhea. It's the GI section. Um, I don't know if they chose that color specifically for that. We can find out. This covers a number of different entities that affect the GI tract. So diarrhea of unknown cause, which is actually much like the cold thing, it is most causes of diarrhea, right? We do not test for what caused it because the answer to most of them is the same. It's a viral diarrhea, whether it's rotavirus or norovirus or some one of the other viruses out there, it is all treated the same way. There's bacterial gastroenteritis. And by the way, the gastro part means the stomach, and the enteritis part, the enter, is the intestines. And itis just means inflammation. These are things that actually are reportable because they are more serious. Typically, you see bloody diarrhea, so most diarrhea is not this, but these are things like Campylobacter, Salmonella, Shigella, and then certain types of E. coli, and so on. These are often foodborne illnesses. They can be from improper food handling and all, or food that has not been properly processed. Raw milk, for example, major source of, or significant source potentially of Campylobacter infections and so on. You can also have gastroenteritis that's caused by parasites. Okay, we haven't mentioned parasites yet. They are not bacteria, they are not viruses, they are larger than that. Um, uh, they are microscopic, however, in this case, Cryptosporidium, which can be in some water supplies sometimes, or Giardia. Giardia is very common out in the wild. So um, family comes in, oh, we were hiking with our kids and there was this beautiful, clear, pure mountain stream. Yeah, it wasn't as pure as you thought it might be. It probably has Giardia. Bear poop often contains Giardia. So again, we don't test for that the very first time diarrhea shows up, but if it's something that's been going on for a while, yeah, we may be. Um, whoops, if you can keep there. We mentioned viral gastroenteritis, hepatitis A, which is viral, which is vaccine preventable. Notice the little icon. Pinworms, which are very common, even here in the US. Kids put stuff in their mouths. It happens, easily treated, not a huge deal. And then finally, significant infections like C. diff, which are often a side effect of too much antibiotic treatment, can actually leave you vulnerable to C. diff. Next slide, please. All right, now we have skin and rash. Again, this covers a lot of things that don't necessarily afflict only the skin, but the main thing you might notice first is something happening on the skin. There's fifth disease, also known as slap cheek syndrome, bright red cheeks. It's caused by something called parvovirus, largely harmless to most people. Can be a concern, however, for women that may be pregnant. There can be some fetal effects, and that's really the main time we actually think about it much. Hand, foot, and mouth disease, which is caused by the Coxsackie virus, very common, also not a big deal, does not cause much harm. Impetigo, which is a bacterial skin infection caused by staph or group A strep. Lice, which everyone is familiar with, head lice. And that makes that can cause some challenges as well. Measles, which again we've seen a few outbreaks. There was a bunch in early childhood centers in Chicago in the last year. Ringworm, which is a fungal skin infection. Roseola, which is a viral infection causing a rash. rubella, which is also vaccine preventable, scabies, which is caused by a microscopic mite, shingles, which is also vaccine preventable. When you vaccinate against chickenpox, you're protecting against shingles, which is a re-outbreak of chickenpox. Other types of skin infection that involves the Staphylococcus bacteria, and then, as I mentioned, chickenpox itself. Next slide. And the new one they added here was the staph skin infection because this is something that's become more common, including some strains of staph that are bacterial resistance. That is our problem again in healthcare to think about, and if that changes anything, you should be getting guidance on that. All right, meningitis. This is the thing that scares everyone, right? You may wonder what in the world. I mean, we often know meningitis, something with the brain. What are the meninges? They are the lining around the brain and spinal cord, and so on. Karen, I see your question, and let me just answer it right now since we were talking about chickenpox. You asked, is it true that if you've had chickenpox, you are more likely to get shingles? Yes, because what happens is when you've had chickenpox, the virus never actually leaves your body. It actually hides out in your nerve cells, and then if it reactivates even decades later, it can cause an outbreak along that one nerve. That's why you get a patch of shingles or something like that. So if we prevent people from getting chickenpox in the first place, then you are preventing shingles. So I'm old enough that I had chickenpox when I was young. Used to see it all the time when I started in practice, etc. I'm at risk that there could be a reactivation of that and causing shingles. Any of you that are young enough that you got chickenpox vaccine as a kid, you are highly unlikely to get shingles. It's not a guarantee, but you're highly unlikely because you would have never been infected by the virus in the first place. All right, back to meningitis. Meningitis is the lining of the brain and the spinal cord getting inflamed. And if it's bacterial meningitis, it can be really bad. It can cause permanent brain damage. It can be fatal. Here's the great thing. Look at those three items there: hip meningitis, meningococcal meningitis, and pneumococcal meningitis. We immunize against all three of these. It is so rare now that I see any meningitis from this. Have I seen them? Yes, I have. Some of them was before we had vaccinations for these, and some are in cases where I have seen a child who was unimmunized, and took one look at them and said, "Yikes, this kid is much sicker than typical." And I sent them immediately to the emergency room. They were going to need way more than I could do for them in an outpatient setting. And indeed, they had bacterial meningitis. We got to them in time, got antibiotics on board. They did okay, and were eventually discharged home. But that was very very nerve-wracking. You can also have viral meningitis, which can be fairly mild sometimes, can be more severe, but needs time to kind of to get better, but is less of an issue typically. All right, sexually transmitted infections. We will not spend a whole lot of time on this because you should not be seeing most of these in your childcare facility. Can you have issues like, next slide, please. Highlight there. Yeah, something that was added was congenital syphilis. So this is where the mother has syphilis and it gets passed to the baby at birth. And that is a case where you would have to think about syphilis, or at least we have to think about syphilis. There should be a full treatment plan already in place. And if there's anything that you need to know about how to treat that child differently, that is something that's direct information that should be given to you. Most of the rest of these should not be a concern in the age group that you're working with. Do remember that this chart is also used in summer camp and in school settings, right? So these are things that somebody who's working in a high school setting may need to be thinking about. So you may be wondering, like, why are we talking about gonorrhea? Because it's not just for early childhood settings. All right. Then, as noted, they talk about the on-site control and prevention measures, and they group them in a couple of ways. How do we consider all the diseases in this category, and then what are the specific measures that are needed? Next slide, please. So, ears, eyes, nose, and throat. Notice here it says for all of these, yes, good hand washing and hygiene. All the things we've been saying, right? Avoid kissing, sharing drinks, or utensils, use proper disinfection of surfaces and toys, and so on. However, they point out for mumps, you may need to provide immunization records to public health officials. And for strep, they are a little more specific, right? They mention some of the things that were above, but also if you're a food handler and you're infected, you shouldn't be there. And then minimize contact with respiratory and oral secretions. So just to provide that example. And we're not going to walk through all of them in detail because they're all on there. Now, exclusion considerations. Please, please, please realize most childhood illnesses do not require exclusion. Okay. The majority are self-limited viruses. They are not significant or severe. And excluding a child, especially once they develop symptoms, they've probably been shedding virus already before they developed symptoms. So sometimes exclusion doesn't keep anyone else from getting it. You're closing, to use the metaphor, you're closing the barn door after the horse has already left, right? That the exposure's already happened. So when we say that it does not require exclusion, this has been made on a lot of data and a lot of thinking through, are we actually protecting anyone from anything significant in that situation? So what are the three key criteria for exclusion? If you are a long-term attendee of our webinars or listen to the podcast or anything like that, these will be familiar. And if you're not, hey, we're glad to share these with you. One, in general, like look at specific exclusion criteria, but in general, there's always kind of these three caveats that are out there. If the condition that a child has prevents them from comfortably participating in activities, if they require greater care, these are or, by the way, or it requires care greater than you can provide without compromising the care of other children, or it poses significant risk of spread of significant diseases. Okay, then those would lead to exclusion. Let's talk through a few of these specific criteria. So, fever, okay? We get a lot of things about fever in healthcare, right? Please remember, a fever is defined as 100.4 Fahrenheit or greater, okay? 99 is not a fever. It is not even a low-grade fever, okay? It is simply a higher end of normal body temperature. We've talked about that on webinars. We've talked about that on the podcast. And you notice it does say there must be a fever and behavioral change or some other symptom. Okay, so if a child is merely warm, but they're okay, and you're like, they're 100.5, that's okay if there's no behavior change, no other symptoms. It may be that they just finished playing outside really hard, right? And there can be a temporary elevation in body temperature. We want to make sure that we're excluding children because they're actually ill and not because of some short-term issue that's there. Next, please. Vomiting or diarrhea, of course, and we'll talk about that in a little more detail. Next, please. And then, of course, if there's a rash plus a fever or behavioral change, that too can be a reason for temporary exclusion. A rash on its own, if there's no fever or no behavior change. So if the child seems uncomfortable, they're itching all over, they have a fever, anything like that, and a rash, by all means, that's exclusion. But the rash on its own does not necessarily mean that. So again, fever, any route is fine. Under the arm is a common one, also by mouth. Please remember, do not add or subtract your degree based on the route. Please stop doing that if you're doing it. If anyone else is doing that, tell them not to do it. I've actually had situations where we've created a fever where there was none because of adding or subtracting numbers. And only take the temperature if the child feels ill. COVID, I know we did temperature screenings. We were doing the best we could with a pretty messy situation. But now it's back to normal. Do only take temperature if a child feels ill. We need to think and consider the child, not the thermometer. This is actually what I tell parents about even treating fever at home. If your kid is acting fine, don't even take their temperature. Take their temperature if they're not acting fine, and if there's a fever, sure, consider giving them something for it. Treat the child, not the thermometer. And again, exclude until fever-free for 24 hours without the use of fever-reducing medications. This is basically because fever itself is not harmful. Fever itself is not infectious. But fever is a sign of the body's response. It's our immune response to something. And you can argue that if there's a fever in play, that the body's dealing with something more significant. And that's a good enough indication that you or parents can use to say, okay, they probably should be out if there's a true fever and that fever is present, and of course not masked by Tylenol or ibuprofen or anything like that. All right. So how do you request a wall chart? You can request it from your local or tribal health department. And of course, you can request directly from the Wisconsin Department of Health Services. That was the link that we provided earlier. And again, this is your state tax dollars at work. Here's some other resources that she provided. Again, the whole communicable diseases division in the Department of Health Services. They're great folks. Um, and of course, us at Wisconsin Early Childhood Health Consultation, and then of course our friends at who write Caring for Our Children, the National Resource Center for Health and Safety. And these are the references that were used, many things that are familiar, images of our DHS or are publicly available. And we will now go to the section that we also wanted to share with you, which was some guidance that we at ECHC have about using the communicable diseases chart. I'll say a few things here. Um, and First of all, we approached DHS, gosh, I think about over a year ago, and we said, hey, this chart is wonderful. Many people in the field rely on it. We've noticed some things that could use some updating, or that might not be so clear, or that are really leaving the door open for misinterpretation. Could we sit down with you and talk about these things? And our team had already worked through kind of careful walk through each section of the chart and made some recommendations. Again, it's DHS's chart, so we didn't have the ability to change it ourselves. They were very open to making it better. And we had some great thoughtful conversations with them. They went back, did some revisions, and we got to look at a draft version. And then in March of this year, officially they released the new one. It took us a while to be able to get this webinar scheduled and timed and all. So we're thrilled with it. We're actually much happier. It's fixed a lot of the things that we were finding were problems, and updated some things. Here's a few key things that I want to make sure we underscore, and I've kind of done it as we've talked, but I want to make sure that we underscore kind of almost like a user's guide to the chart here. So we just went through this, right? Remember, most childhood illnesses do not require exclusion. Okay, hanging this chart up should not send the message to anyone that like, oh my goodness, there's all these things that we're going to have kids out left and right. Like, no, not necessarily. And remember always these three big global things. This is the full language from Caring for Our Children, and this is also on the bottom of the chart. The child is, and on the bottom of the chart has the language you saw before. Here's the full things. The child does not feel well enough to take part in normal activities. Child needs more care than teachers and staff can give while still caring for other children. And whatever the illness is, has a risk of spreading harmful disease to others, right? So giving someone else a cold, sadly, that's life. And you can argue that's unavoidable. Giving someone else measles, yeah, let's not do that. Okay, that's something that we should be avoiding. Next slide, please. Remember that the common cold comes into that line of other respiratory illnesses or respiratory illness of unknown cause. This is going to be the vast majority of stuff that you encounter is right in that line. Next, please. Remember that fever is only significant if there's a behavior change, all the things that we talked about. Here's something that I want to point out. There are two columns that are similar-ish, but not the same. There's a thing saying time period when person is contagious. That is actually not a useful column for you folks because some people can be contagious for a long time. Sometimes even you'll notice if you looked at the chart, some of them even say you could be shedding virus for weeks. That is okay. The column you should be looking at is the criteria for exclusion column, because that's what tells you, do you say this child can't come back, or yes, they can come back? That is contained in that column. And those are sometimes the same guidance, but they can be different, and that can be confusing. If I were you, I would never ever look at that time period when person is contagious column, because it doesn't tell you what you need to know. The criteria for exclusion is really the key one. It tells you when they should be leaving the center and when they can come back. Again, many of these things are common. A feature of this chart that can be confusing or concerning is that sometimes you say, wait a minute, there's one line here about measles, which sounds pretty awful, and it can be. But then wait, RSV, pink eye, hand, foot, and mouth, which are very common, not major issues in many ways. So this, because they're on the same chart, does not mean they have the same severity, right? Many are common, and it is normal to see these things. Do not freak out if you hear about a diagnosis of RSV or pink eye or hand, foot, and mouth versus, say, something like measles. And of course, follow the listed exclusion criteria. And if you're not sure about like a particular illness in general, hey, give us at ECHC a call or an email or text. We're always happy to do those things. And we have our consultation team, and I'm happy to turn it over for a few moments to one of our nurses, Kristen, to talk a bit about consultation before we go to questions.
Thank you. Hi, everyone. My name is Kristen, and I am one of two nurse consultants with ECHC. You can see Kelly's our other one. And I really want to encourage you all to reach out to us if you have questions about, after the Q&A, do you have more questions about anything that was talked about today, questions about any other health and safety topics? We are so happy to help, and you will hear back from either Kelly or I. And I want to talk a little bit about kind of the process that you'll go through if you do reach out to us. So this is a visual framework of our consultation process, but I want to talk through it a little bit just to help it make more sense. So obviously the first thing is you guys need to reach out to us with your questions. Text, call, email, our website. And then either Kelly or I will most likely reach out to you to get more information about your question. Sometimes the information in an email doesn't quite help us get to what you really want to know. And we want to make sure that we give you the information you need. After we have that conversation, we kind of go behind the scenes and gather our resources. Maybe we're reaching out to other partners to help with referrals, because we also can't answer every question that you have, but we want to help guide you in the right direction. After we've done that work, we'll connect with you again, whether it's by email, phone, Zoom meeting, to kind of go over any other resources, any other information, maybe get you connected with some of those referrals. And then finally, after this whole process, we do follow up, and we just want to make sure, hey, have any other questions come up? Did this answer your questions? How else can we help you? Because you'll see at the center, trust and collaboration is at the center of this whole process. And that's because we want to make sure that we help you now and that you trust us to reach out again in the future so that we can have a partnership going forward. So again, please reach out. We are so happy to help. And I will turn this back over now for question and answer.
Thank you so much, Kristen. We so appreciate the work that you and Kelly and me backing you up on consultation. We try to do the best we can through podcasts and webinars, but we recognize that it doesn't cover every situation, or you need to know a little bit more or need more resources. Please make use of consultation as need be. And I'll just re-highlight, everything we provide is free. We have no way of, I don't even know how we charge any of you, and we don't want to. So, all right, questions. I'm seeing a whole bunch of things in the chat here. So for your questions, please, either in the chat or in the Q&A, and I will just start jumping right in here. So let's see. Would we prefer that folks outside Wisconsin not order the charts? Thank you, first of all, for joining us if you are outside of Wisconsin. That's a question for DHS, and I can't speak for them. What I would do is on those pages, there's an email address, and you can ask them if they'd be willing to send one. Do keep in mind you can always download the PDF version and find a way to print it yourself if that is the case. That is certainly not being restricted. I also want to point out that we at ECHC have a guidance document, those final kind of points that I made about, thinking about fever and most of these illnesses being common and use the exclusion criteria column and not the others. We have put that together in a beautifully designed document that is summarizes all that and that you can hang up next to the chart if you'd like. So and we will tell you more about where to find that in a few moments. Which illnesses should we be posting to parents about? Just the quote unquote reportable ones? That's a great question. And I think using the ones that are reportable as a guide is a good one. Do remember things like pink eye are not actually reportable, and many times, like I get told, "Oh yeah, we were told that there's pink eye going around." You need to also just read the room in a sense, right? What are the parents in your center interested in hearing about or not hearing about? Do they want to hear about every small thing, or do they want to know just about the big deal ones, and so on? But I would start with at least the reportable ones because if they're reportable for a reason. Which ones for sure need to be told to a licensor? That is a great question, and we will talk to our friends at licensing to ask specifically about that because I don't know the answer off the top of my head about that. I imagine reportable illnesses, yes. I don't know if it goes further than that, so we can find out. What does it mean when it says on the request form, do not order more than a 3 to 6 month supply? I think they're trying to avoid people asking for, 8,000 of these and then they have none to share with anyone else. Most of the time you're posting these, I cannot imagine that you're, needing a new one every month or anything like that. Um, all right. I'm going to switch over to the Q&A for a moment to make sure I'm getting to those folks. Main difference between impetigo and hand, foot, and mouth. Impetigo is a bacterial skin infection. Hand, foot, and mouth is a viral infection that actually affects the entire body. They're completely different causes. Impetigo generally needs some treatment, usually with a topical, like a cream that you apply that's antibacterial. Hand, foot, and mouth, like most viral things, will go away on its own. So they're completely different things. Can you get shingles more than once? Yes, that virus, you can't get rid of it once it's living in your nerve cells, like any of us that have had chickenpox, and it could reactivate at any particular time. There are vaccines for adults that help reduce the risk of shingles and other ways to kind of reduce the chances of that happening. I am a pediatrician and not an adult medicine doctor, so I can't quote you when to get those or not. But those are out there, and there's guidelines for those. I was not vaccinated as a child. If I came into contact with a child with whooping cough, how severely would I be sick? Would you recommend me to be vaccinated as an adult? So, whooping cough or pertussis in children older than, say, infants and toddlers is an annoying cough that does not go away for like a long time and does need treatment, but it is not fatal or severe. In infants, it actually could be fatal. For time, I will not go into details on that. We're working on some possible education around that as well. But if you, as an adult, get it, whether you're immunized or not as a child, it would not mean you would be more severely ill. Would I recommend that you be vaccinated as an adult? I certainly would, as long as you've talked to your doctor about it. And yes, the tetanus booster that most people get every 10 years is often also containing a whooping cough component, the Tdap vaccine. And the reason I recommend that strongly is because you do not want to get pertussis and give it to young children in your center or home or anywhere else, okay? Because it is a much, much more severe illness for infants. So let's not give it to them. Someone is just clarifying, we no longer need to exclude for fever unless there are behavioral changes. Correct. The temperature above 100.4, if the kid is acting fine and there's no other symptoms. Okay, so maybe they're acting fine, but they also got the snotty nose and this and that. Then you need to work down your exclusion list and all. but just a higher temperature on its own, because a lot of kids were getting sent home for simply a temperature that was up there, but they were fine. And then we see them, and the parents are like, all we were told was the temperature was high. How's your kid been acting? Great. Any runny nose, any cough, any vomiting, any diarrhea, any fatigue, any loss of appetite? Nope, 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 nope. Okay. Has their temperature been since you've been home? Fine. I'm not even sure there was an illness there. Okay. Which illnesses need to be posted or made aware? We talked about that in the reportable. Where is a chart usually posted? Anywhere you like, wherever you find it useful. Do you need an RSV vaccine every year as an adult? I would have to look that up, but I can say pretty confidently it's not every year because RSV does not mutate like flu or COVID. I do not know how frequently it is since I don't have to deal with adults. With staffing being so difficult in the field, keeping staff healthy should be a priority. Shouldn't we be limiting exposures to adults who care for those children? That is such a great question, and I've heard it many times. Let me be clear about this. Just because a child is ill does not mean you as an adult automatically will get illness. You may notice adults get far fewer infections, viral, common bacterial stuff, whatever, than kids do. Part of that is because we're not shoving objects in our mouth all the time. But part of that is that our immune system has developed memory of many of these things, either through being exposed or vaccination throughout our entire lives. Okay. So I am much less likely to get most of the things. I mean, hello, I work in healthcare. People literally bring their ill children to me to cough on me. Since COVID, we've generally all been masking, so that reduces the risk, right? But people are bringing their sick kids to me, and nowhere do I get anywhere. I don't get ill all the time. In fact, I rarely get ill. Um, and that is because I've developed that immune memory over time. So if you were to say, well, we can't ever have adults ill, so we can't have any sick children here because they need to be able to work and so on. Well, honestly, and I'm being silly here, but we should shut down all childcare forever because young kids get ill frequently. This is their job. This is normal human beings, normal human behavior, normal development of our immune system. So we shouldn't be thinking about it as a we can't have any young ill children here because the adults might get sick, because the adults actually may not get sick at all. Hence why we aren't saying exclude for these common illnesses, because you probably have developed immunity to that over time. But number two, it's also an impossible standard. Also remember, kids are shedding virus, as I said earlier, often before they even develop symptoms. So you're also getting exposed then. You know, again, let's not set up an impossible standard that none of us can meet. So great question. I appreciate you asking it because I think it highlights a lot of things about the immune system that we've actually been talking about at ECHC about how do we talk about the nuances of the immune system and how it works. All right, coming back to the chat, we are located in a school, and with lice, we are completely different in when we exclude. If they're at school and they find lice, call the family and send them back to their class. At the child care center, we are NIT-free. All right, no one should be sent home immediately if they have head lice. The head lice have actually probably been in that head for as long as 2 weeks. Itching doesn't start until lice have actually been there for a while. It takes a while to get sensitized to them. So you're not saving anyone by sending them home immediately. Back to the classroom is fine. Don't go sharing hats or hugging or whatever, right? But and then they should be treated immediately that night. NIT-free is not recommended by anyone. If you look at American Academy of Pediatrics policy on this, many nits are actually dead in the hair. They're just kind of glued on there, but they can't hatch new things. So NIT-free policies have been not recommended for a very long time by the American Academy of Pediatrics and others, including caring for our children and so on. So if you reach out to us at ECHC, we'd be happy to help you craft a better lice policy around that. Is this training going to be available to watch again later? Yep, we will have this online, as with many of our webinars. Thank you for all the wonderful thank yous and appreciations. All right, can you talk about thermometers again? Our underarm one says to add a degree. Throw that thermometer out or scratch out that thing. That is old advice. I literally had someone bring their kid in saying, my kid has a fever. They noticed it at childcare. Okay. And no symptoms, nothing else, acting fine. And then I finally asked, was that the number on the thermometer? No, no, no. The number was this, and then they added a degree. And it's like, okay, we have manufactured an illness where there is none. Do not add or subtract degrees. Just whatever it says is what it says. What kind of language would you use, or resources would you provide to staff who are immunocompromised or still worried about COVID and want to see loosened exclusion policies? Yeah, this is a hard one. So this is somewhat less about the science, and it is more, I think, about fear, worry, and anxiety. First of all, if staff, and also the word immunocompromised is a tricky one because a lot of people say, oh, I'm immunocompromised. Okay. There's a whole range of things that constitute immunocompromised. We have the people who literally have no immune system, right? Who are getting severe chemo, like pre-bone marrow transplant, and they're not even allowed to leave a room in the hospital, right? They're not going to be working in your center. And their visitors have to talk to them through glass because it is such a high risk, and so on. And then you have folks who might have a tendency towards getting colds easily or something like that. Um, is that immunocompromised? Probably not completely. I get it that that they just tend to get colds. What I would say is that if you reach out to us, we can perhaps help you with some resources and some language around this. I think we need to recognize that being around small children get a lot of illnesses and shed a lot of virus. If someone is truly immunocompromised or is truly worried about COVID, saying we need to have exclusion policies that are broader is probably not the way to go because again, we know that people shed virus without even having symptoms. They may never develop symptoms. Um, that's not going to protect them. So I think that necessitates a different kind of conversation there. Comment about a lot of kids being diagnosed with RSV. Yes, and I'll tell you that's a phenomenon of the fact that we have swabs that we can run that just tell us yes, they have RSV or no, they don't. Those kids have always been there, year after year after year. We just generally didn't do that. And I'll be honest here. I personally don't understand the value of those swabs because if you have RSV or you don't have RSV, I'm going to give you all the same instructions that I did in either case. So we're sometimes spending a lot of money on that swab for not really changing much that we do. It's just that we're running them sometimes left and right, and we didn't do that even like 5 years ago. Discharge from the nose. Nope. The color of the discharge from the nose does not indicate infection. We've covered this in some other webinars and on the podcast, but I'll just say it again here since you asked that a great question. That color does not tell me anything. I wish it did. My job would be so much easier. Have they made changes for temperature taking? We just addressed this again. Do not add a degree. Stop that, period. Why do we have flu on the chart and are not listing COVID? Yeah, COVID comes into that grab the all catch-all territory. That's the word I was looking for. That's a good question, and I'd have to ask DHS that specifically. I think the reason for that is because influenza is there is one difference. There's two differences with influenza. Well, influenza is vaccine preventable, as is COVID, right? Or at least it reduces severity of both those conditions if you're vaccinated. So that's a good thing. We do have antivirals for both entities that can be done. I think COVID is still shifting enough that I think they decided that to put a separate line for it versus influenza, which we have decades of experience with, that to put a separate line for COVID runs the risk that the chart would be out of date very quickly. And hence, please go look at latest CDC guidelines or health department guidance for that. I think they were trying to avoid putting something that might become out of date way too quickly. All right, thank you for this important information, especially around temperature taking. Will there be a Spanish session on this topic? We are not planning a separate one on this. I do want to say for everyone who comes to our webinars, we have been trying our hardest to make sure we have Spanish language interpretation. It has been a very difficult job in terms of getting a reliable contractor. I'm just going to be frank about it. We think we've finally found one, but it's going to take a little bit to get them in place and all. So with that, I will stop there so we can wind up. If you have other questions that we didn't get to or questions that occur to you later, please, ECHC is here for you. Thank you so much for all that you do. Maria, I'll turn it back over to you.
Great. Thanks, everyone, for this engaging discussion. As we wrap up our time together, we'd like to highlight the Early Childhood Health Consultation's various services that are available, all completely free to you. In addition to the webinar trainings such as this one today, we have our podcast, Teachers, Toddlers, and Tissues, which has monthly podcast episodes. We also have a resource library that includes print and video resources on our website, as well as the health consultation services that is growing to expand with the goal of statewide support that Nurse Kristen talked about today. Our podcast collection now has 21 episodes available. Feel free to check it out if you listen to your favorite platform, or you can go to our website to learn more. Our health consultation service locations are expanding. We're excited to share that we are currently supporting approximately 4,200 active early childhood providers across the state, again, with the goal of statewide support. If you're interested in learning more about the specific locations, feel free to go to our website or reach out to us with more questions. You can reach us by phone call, text, email, website, or you can follow us on social media. We'd like to say a special thanks to the many early childhood care providers who offer us ongoing guidance, including our very own advisory board of early childhood providers. We'd like to thank our colleagues from other childcare health consultation programs across the United States, our current project partners, and our past project team members. A few logistical reminders as we wrap up today's live webinar event. In a moment, we will include a survey link in the Zoom webinar chat. That is the route to take if you're interested in registry credit. Feel free to click that survey link and enter your information via the survey for registry credit. Also, following the event, you can expect a link to today's recording and the survey link just in case it's needed if you attended the live session. And then within 2 weeks of today's live event, if you entered your attendance information through the survey link, you can expect that information on your online account through the registry. If you're watching today's live recording, feel free to check out DCF's Continuing Education log if you're interested in continuing education credit. So now I'd like to direct your attention to the Zoom webinar chat where you can locate the post-webinar survey link. If you're using a mobile device or cell phone, please locate the bottom panel for the chat where you can select the icon for the survey link. And with that, I will turn it back over to Dr. Depeche Nazaria for closing remarks.
Thank you so much. Thank you for all the great questions. Again, this just underscores to us just how much you have questions and how much we love providing you with answers, new ways or other ways to think about these issues, and just really try to think as hard as we can about how we can keep kids safe and healthy and be able to serve them and their families well. I would be remiss if I did not just note Maria, who's the voice that you hear at the beginning of every webinar and making this all go, is moving on from our program at the end of this month. But we will still be here providing our services and our webinars and our podcasts and consultation to you. But I just want to just give kudos to Maria for all the great work she's done over the last several years to really grow this program. So thank you, Maria, and best of luck to you. And just also thank you to all of you for the work that you do and for putting up with me pinch hitting on this webinar. If any of our friends from DHS are listening live or on a recording, I hope I did justice to the fantastic work that you've done on this very useful, very heavily utilized chart. And really just hope that this has all been very useful to you. And thank you for all that you do. Happy December and a happy festive period to everyone. And we'll see you again in the new year. Thank you.